Whosoever will be saved, before all things it is necessary that he hold the Catholic faith.
Welcome to Veritas et Thus, or Truth and Incense, a podcast covering the one holy Catholic and Apostolic Church, the faith, and the liturgy, which is the public expression of that faith, especially as seen through the Anglican heritage. I'm your host, Father Gregory Seeley, rector at St. Thomas of Canterbury in Roanoke, Virginia, and I have a returning guest on, AJ Reinhardt, who is a therapist, a clinical therapist, and PhD student. We'll say candidate because I'm sure it'll be soon. We talked previously about autism. I'm having him back to talk about actually his area of specialty, which is schizophrenia. So, really cheery subject here. I'm curious because we don't hear a whole lot about schizophrenia in the media. Very few people talk about having it. And whenever it's brought up, it's inevitably brought up in horror stories or monsters. There's a Netflix series right now on Ed Gein, and he's portrayed as a schizophrenic. And these are hearing voices, other personalities, things like this. So let's talk for a second. Because this is your expertise, what are the symptoms such, and how common or prevalent really is schizophrenia?
Yeah, absolutely. Appreciate you having me on again, and happy to chat with you about this. I agree with you. I think that the view of schizophrenia, particularly in the media, is fairly sensationalized. When it comes to the practical day-to-day interactions with people that are actually diagnosed with the disorder, um, a very different presentation in my experience, having worked with that population for the last 10 years or so. But really, schizophrenia and schizophrenia type disorders are characterized primarily on the positive end of symptoms, which is going to be your hallucinations and delusions, right? And so auditory, visual, tactile hallucinations, and then there are various different types of delusional disorders or delusional aspects, like paranoid would be one a lot of people are familiar with, thinking the government's after me, or persecutory, things like, oh, people are trying to attack me, even things like erotomatic, where we have delusions of people being in love with me, like things like that. So delusions have a bit more of a spectrum, but schizophrenia is characterized by those positive symptoms. But more importantly, and I think this is actually more related to what I end up doing in my day-to-day life and practice, is helping people with the negative ends of schizophrenia, which are your secondary symptom problems, which you've got disorganization in thought and speech, trouble with memory and processing, executive functioning difficulties like maintaining organization on tasks, focusing appropriately, communication and social norms, eye contact, like social, like reciprocity back and forth. And even more, I think, profoundly for the individual is going to be things like anhedonia and avolition, which are going to be a limited ability to feel certain things. That's where you get kind of that flat presentation that you might get from some people with schizophrenia. And then avolition being just a limited drive for motivation to do certain things, right? So, like, getting a job, like getting up and taking a shower, cleaning your house or your room, right? Like, these things are fundamentally disrupted in these individuals. And so those two areas are the main categorical things that have to do with diagnosing schizophrenia.
So initially you say, having disordered thoughts and zoning out, I'm like, wow, I might be schizophrenic.
Yeah.
Is this a spectrum the same way that autism is, and how, if someone were to say, well, I have a hard time organizing my thoughts and easily get, distracted, is there something more to it, or am I just, am I other factors? I mean, how, again, is this a what's the term I used a second ago? I just forgot.
Spectrum.
The spectrum. Thank you. Is this a spectrum, or and what goes into a diagnosis of schizophrenia?
Sure. So I'd be wary to call it a spectrum. I would say that there is a spectrum of symptom severity, perhaps. But schizophrenia has some differing, like schizophrenia and schizophrenia type disorders, or psychotic disorders, more broadly speaking, right? Are have different categories within them depending on the presentation of the symptoms. And so, for example, a person who has disorganized thought is not going to meet criteria for schizophrenia because you do need the presence of the hallucinations or the delusions alongside these other issues that exist in day-to-day life, right? Both of those things have to exist. It's just that what causes more problems functionally in day-to-day life tends to be those negative symptoms on the back end. But yeah, there are a couple of different categories within psychotic disorders that we look for depending on what the person's presenting with. Schizophrenia is going to be more broad in its presentation of specific like um, uh, the positive symptoms of hallucinations, delusions, plus these other symptoms. But the main thing we look for is how it's related to mood, depression and anxiety, and mania type symptoms, right, would be an area that you would categorize differently, right? So, for example, a person who has hallucinations or let's say delusions that are only present when that person is depressed, right? Like if they're not depressed, they don't hear voices, they don't have delusional beliefs. It only happens when there's these severe depression, these depressive episodes. We might be looking, for example, at depression, like major depression with psychotic symptoms, or potentially a schizoaffective disorder if they have the manic side as well. That's like mood congruent, right? And so the categories of schizophrenia or psychotic type disorders, there are more categories, but I would not necessarily put it on a spectrum the same way that I would put autism on a spectrum.
It sounds almost what you're saying is that it could almost be episodal autism. So if you have depression or something happens in your life where you're depressed, whatever it may be, then elements of schizophrenia would manifest, which might go away were that depression to relieve itself.
Yeah, sure. You can have things like, for example, brief psychotic events, right? And so, like, people that have experienced intense traumas, for example, can have brief like episodes of psychosis that are not permanent, right? That alleviate themselves over time. That would not meet criteria for the like 6 months plus that we see for schizophrenia, right? Like that you have to maintain these symptoms for set periods of time, devoid of like mood change, situational, environmental changes, like these symptoms are present kind of pervasively, regardless of what's going on in your life, versus other psychotic symptoms that can manifest as a result of mood, environment, and other things like
Okay.
that. And they'd fall into the category in the DSM of like psychotic disorders, but they would just have different, like, they wouldn't present the same diagnostically.
How often is schizophrenia, just when it's violent or um, that would kind of fall into that kind of monster category? How often are people with schizophrenia? Uh, uh, um, if someone's after you, how likely are you to go there and kill them because they're after you, because your voices tell you, kind of thing?
Sure. Now, some of this is anecdotal. I don't actually have like the statistics on violent crimes associated with schizophrenia. Anecdotally, my experience with people with schizophrenia has been very, very rare that they become aggressive or violent. Like very. I think I maybe have one or two scenarios in nearly a decade of working with that population where somebody has become irrationally violent. Um, One of the things that I tend to look for that relates to that tends to be the command things called command hallucinations, which can be a bit of a red flag for me as far as what psychotic symptoms a person's experiencing. So command hallucinations would be that you're hearing voices, but you're hearing voices that are telling you to do things, like do this, don't do that, do this, which is a fairly more rare manifestation of hallucination. But when people have those, I tend to be a little bit more worried about potential like acting out in some way, shape, or form, because the presentation is like, well, somebody told me to do it, right? But in my, again, anecdotal experience, like I have one, maybe two scenarios in that entire time where I have had a person with schizophrenia that has been violent or aggressive in some way that is beyond, you know,
Right.
like, discomforting level of like getting annoyed or frustrated or angry.
So the history of schizophrenia, there's almost kind of caricatures, and I think the movie was Arsenic and Old Lace, but I could easily be
Yeah.
wrong about that. But one of the characters thinks he's Teddy Roosevelt, and he
Mhm.
charges up the stairs and what have you. How real is that in schizophrenia that you assume a whole other persona?
Yeah, again, I think that a lot of these. It depends on the type of delusion, right? And so, for example, that would be something that I would categorize in the area of like a grandiose delusion. Like they have grandiose delusions, which again is a subcategory of of delusional type. As far as prevalence compared to other types of delusions, again, I don't have the number on that, but I would say it's not an inaccurate caricature, like a caricature of the disorder, particularly if there's grandiose elements. I've clients in the past, for example, will think that they're famous rappers or like some other famous individual somehow, and they'll even talk and act like a person who is famous, right? Like, oh, I'm being paparazzi is following me or trying to take my picture and things like that. And so the grandiose delusional element there, yeah, like there are people that I have encountered that have had pretty intense grandiose delusions where they genuinely believe that they are that person.
Next I'm thinking of is the one from Alfred Hitchcock's Psycho, which I guess was basically based on Ed Gein, but there was the character was tailored, and that was the mother. And this mother died, and she kind of haunted him, and he would take on her persona from time to time. He was him, but he also had this secondary personality, which wasn't him taking on it was the same way as this kind of like grandiose, but there was a second person, almost like split personality. Does that fit into schizophrenia as well?
I don't know if the split personality piece would fit in there. I think that's more of delusional end of things. There's a little bit of debate around like the dissociative identity stuff when it comes to psychotherapy and psychologists. And I tend to lean in the direction of it that it's a delusional disorder, that you believe there are multiple personalities in one particular situation. A lot of trauma, background stuff related to that as well. Taking on a persona like that, that seems very intentional. In like when you look at something like Psycho, right? Like that's again very sensationalized as far as like taking on that kind of persona in an effort to commit atrocities, right? And so like I really I don't tend to see a lot of overlap between film and movie representations of schizophrenia and interacting with people in real day-to-day life that have the disorder. um, the We see that more with individuals who are suffering from like severe personality disorders, chronic repetitive trauma, and those things can sometimes manifest in psychotic type symptoms, right? Like if you've had chronic repetitive trauma throughout your entire life, it can reinforce the manifestation of psychotic symptoms. But yeah, I have very rarely have I encountered a film or movie representation of schizophrenia that I have found to be close to actually interacting with those people on a day-to-day basis.
Interesting. The last one, and people listening to this or watching this won't know who I'm talking about, but you were familiar, was we had someone at the parish about a year ago or so who claimed to be schizophrenic. And I didn't meet him really well, but he was an indigent man who was needing charity from us and he didn't always ask nicely. But he claimed to be schizophrenic, and I never saw that he ever interacted with any kind of visions or hearing anything. It was mostly a matter of just his thoughts being scattered. Again, this was his claim. How I mean, that would almost strike me as being, because I remember we looked into um, dealing with him, and because he was a difficult person to deal with, how do we deal with him? We looked into some schizophrenia, and people were making YouTube videos on their personal journeys, as people are wont to do. And the person is, oh, I'm schizophrenic, but my thoughts are a little bit distracted, and I take medicine, and otherwise everything's fine. So again, you just said that there isn't a spectrum, but it almost makes me wonder um, how how does schizophrenia most commonly manifest itself in society?
Yeah. So when I say it's on a spectrum, what I mean is similarly, like we have like level one, level two, level three autism. We don't have something like that. You can have varying severity of schizophrenia symptoms, right? But the core baseline of it is that you are having some sort of hallucination or delusion manifesting alongside some of these other like thought disorder type symptoms, right? Which would be the like my thoughts are cloudy and confused, and I think things are related to me that maybe are not related to me, and that type of presentation. But you also have this positive end and by positive I mean hallucinations, delusions are positive symptoms of schizophrenia. A lot of those things are treated very effectively pharmaceutically, right? And so when I have encounters with individuals, especially when they're younger, that are, we call it prodromal syndrome, right? And so they're kind of starting to exhibit symptoms that would be indicative of a psychotic type disorder, and we can get that person interventions and help very quickly. The outcomes tend to be better, right? That person would align, maybe depending on the severity of the disorder and what's going on around it, would align more with what you're talking about on that YouTube video of like, oh, well, I have these disorganized thoughts and I can get kind of confused or paranoid sometimes, but I have medication for that and I have a therapist that I see for it, and I'm able to navigate, right? I have kind of spikes and drops, but I'm able to navigate, right? And then you have on the other end of things people who are on the more severe presentation of like, we're not functional, like we can't maintain a house, we have no habits around, eating well, cooking for ourselves, doing like just the IADL, like daily living skill thing. There are people that are struggling on that end, and what I have found as far as that severity goes is a lot related to how that person has attempted to deal with those symptoms. A lot of people, maybe I shouldn't say a lot, but with some frequency, people with schizophrenia will have a pretty serious, distressing background. A lot of trauma tends to be correlated with that. Even just some like situational difficulties that you would encounter, like difficult parenting situations, difficult support systems around them, and it's been like that for years. And so when they manifest these these symptoms, they try to treat it themselves and will a lot of times turn to things like drugs or alcohol or other, maladaptive skills to try to deal with the distress that they experience. And their support system is very lacking, just because of the nature of that environment. And so what happens is you end up with a 45-year-old or 50-year-old who manifested schizophrenia, around 20, 21 years old, had nobody around to assist them at that point to kind of get them in a direction of support and care and medicine and direction. And then they were homeless, and then there was chronic trauma from being homeless, and then there was drinking involved and drugs involved. And now you've got a person with schizophrenia and all of the symptoms that come with that, with 20 years of addictive behavior, trauma, and substance and homelessness. And now we're trying to treat that person, right? And it's like, well, that person now has more than just schizophrenia symptoms. We now have 20 years of chronic traumatic experiences on top of substance abuse, on top of unmedicated psychotic symptoms. It's a very different thing to deal with. And so, like I said, I wouldn't say there's a spectrum, but like that would be two kinds of extremes of that presentation that you might encounter as for me as a provider. And I see both of those things.
So how treatable is schizophrenia? I mean, depending again, going from your very light schizophrenia to your category, whatever extreme, how treatable are to those?
Yeah, so we have the atypical antipsychotics that have been developed have been very, very effective. We have very good medicine for treating hallucinations and delusions, and even some of the thought disorder stuff. The downside to antipsychotics is that they can be pretty rough on your body. In the long run, you can end up with things called extrapyramidal symptoms, which are like tardive dyskinesia, like shaking and things like that you might experience from chronically being on those medicines. And so that's a downside, and a big part of, I believe, the pharmaceutical industry is looking at how do we alleviate these symptoms without these more serious side effects. But caught early with good support and interventions, it is treatable. Yeah, it is treatable. It just depends on what your expectation is of that person's overall functioning, right? And so depending on their presentation, some people can, I do have worked with people that are married with kids and have that disorder, and they maintain a job. I do have people that are like that. I also have people that can't do that, and they did catch it early, and they are on medication, and they're in a good direction. They function well. They have good coping skills, but they struggle to keep jobs, and their social interactions are very difficult, and so they don't seem to function quite as well. But it is treatable, but it's not curable. We do not have any way to cure that disorder, particularly fully formed schizophrenia.
That doesn't surprise me. Mental illness is very difficult. How how common is schizophrenia in society?
Yeah, so it's so currently it's less than 2% of our population here in the United States. I think globally it's something like 0.25%. It's very low. And so the schizophrenia being moved to, like the statistics around schizophrenia being moved to more of that spectrum look, not that the disorder is on a spectrum, but like we're looking at not just schizophrenia, because that's one diagnosis, but schizoaffective disorder, schizotypal personality disorder, trauma with psychotic symptoms, depression with psychotic symptoms, bipolar with psychotic symptoms. We've added all of the brief psychotic episodes. We've added all of these, category diagnoses to that, to that percentage, and so it's bumped it up to just under 2%. But traditionally, globally, it's around 0.25 ish percent of the population will experience these symptoms.
I want to ask you about how some of our society's problems have perhaps exacerbated or how affected schizophrenia. Before I do that, so don't let me forget to ask you that. But before that, I want to ask: are people who have schizophrenia, do they realize it? Do you ever have to convince someone they have schizophrenia? How or do they ever deny that they have it? How does that work as far as someone who has schizophrenia
Mhm.
coming in saying, no, I am Napoleon Bonaparte. How dare you question me, so to
Yeah.
speak?
Yeah, so from a clinical standpoint, working with these individuals, that's one of the first things I actually try to determine is their level of insight. And so there are some clients that will realize that they have schizophrenia or some type of schizophrenia type disorder or psychotic type disorder, and that it impacts their thinking, um, and their perceptions, right? And so those people I can have very direct, helpful back and forth, like almost cognitive behavioral therapy interventions around, hey, so that paranoid ideation can get in the way here. Like, how are you practicing using like a wise mind scale or other DBT type skills, maybe around recognizing that the thing you believe to be true in this moment is perhaps not, right? And so, what do we do when we encounter paranoid or persecutory thoughts or intrusive thoughts, things like that? And there are people that I can have conversations with. They have that insight. I also have clients that do not have that insight, and they struggle a lot more to do talk therapy. That intervention style tends to switch more to daily living things, right? So I don't really get into the weeds with delusions, particularly if that person does not have insight. It is not helpful to debate a person's delusions if they don't have insight. That is not that is not good practice, right? So as a clinician, if you are debating with your client about their delusions when they do not have the insight into that disorder, that's disruptive. There's no reason to be doing that. The focus being shifted towards things that are tangibly real, like, or more real or comparable, would be like feelings, right? So, I'm being watched by the government. That must make you feel very anxious. Like, we've worked on how we deal with anxiety. How do you deal with anxiety, right? Moving the conversation towards something that's going to be a little bit more practical, and then focusing on daily life skills again. Like I said, hey, are you showering okay? How are you doing, like eating? Are you taking your medicine every day? And then getting those individuals some additional services like mental health skill building or case management, those things that kind of support that building a supportive team around that person tends to be a little bit more important, just so there's multiple touch points for care.
How do you get someone into your office if they don't think they have schizophrenia?
Usually, what happens is a family member will refer that person in to see me, or somebody from the hospital or the local CSB will make a referral to me for outpatient. If they're coming to see me in outpatient, there's a little bit. I'm in a little bit of a niche there, as far as like providing that type of care for people with those disorders, and so they have to be doing okay to get that referral. If they're really in the more severe end of things, or they're probably in a mental health skill building and like partial hospitalization, things like that,
Right.
higher levels of care. But if they're doing fairly well and they're stabilizing a little bit, and I can be a supportive additional person that can talk about the disorder or maybe some IEDLs, they'll get referred to me. So I get referrals from hospitals. I get referrals from local community service board. I get referrals from therapists that are seeing somebody. and then realize there's a psychotic disorder there, and then I get referrals from family members that'll call in and say like, hey, I'd like to refer this person.
So, circling back, and have you some of the problems we have in modern society, increase of divorce, increase of people not growing up with their parents, increase of drug use, um, exposure to drug use in the family, or personal drug use, um, as well as even things like going through a divorce, that kind of stuff. How much has that exacerbated the existence or those of schizophrenia in society?
I think that's really hard to say. One of the things that we, similar to our discussion about autism, um, schizophrenia is not a known. There is not a known origin of we could narrow down into like, oh yeah, this thing is not working, and so they have schizophrenia. It is some sort of genetic predisposition and heritability alongside environmental factors that can cause these symptoms to be exacerbated or even manifest, right? And so we have people that are not genetically predisposed to a schizophrenia type disorder that can manifest the disorder. It's very rare. That's way more rare than the other way around, but it does happen. But the majority is what we see is that if there's a genetic predisposition and environmental factors that can cause that to be the presentation to manifest, right? So if the question becomes like, okay, well, if people are more apt to encounter traumatic events, via neglect, abuse in the home, particularly in the home as children, is that causing a spike in the manifestation of psychotic symptoms? It's like, based off of research and what we see and how those environmental factors impact the manifestation of that disorder, the argument can be made that yeah, there's probably a correlation there, but I don't know the exact evidence statistically. But what we do know is that it is a multifactorial disease, and it is a combination of genetic predisposition and environment. And if the environment en masse is worse, then sure, you're going to get a higher percentage of manifestation of disorders as a result of that.
So, what percentage of your clients have a self recognition of being schizophrenic, and how many of them don't? What percentage?
That is an interesting question. I don't know if I could answer the specific percentage. I would say that it's. I would say that because of my particular level of care, I would say that I am probably exposed to more clients that have higher insight because I'm a lower level of care. And so they're more apt to they're more likely to be able to come in and talk about their symptoms. When I was working in the hospital, or when I was working in Medicaid practice in the community, far less insight, much more co-occurring schizophrenia plus trauma, substance abuse, homelessness, those things, right? And those individuals tend to have less insight. So hard to say a percentage number, but I would say that it's been more since I've been in a lower level of care.
So, when thinking about psychosis and mental illness, sometimes people think about films like One Flew Over the Cuckoo's Nest or Amadeus when he goes and visits the insane asylum, and you see people who are deeply, deeply troubled and have a hard time interacting with the world at all. How often is that the extreme version of schizophrenia?
Yeah, I mean, again, I try to shy away from caricatures, and I don't really care for most media representations of the disorder, and so I'm wary of the comparison. But the but yeah, I mean, particularly as people age, schizophrenia and Alzheimer's and dementia tend to have some overlap with one another, and so that movement from I'm having less high energy psychotic symptoms into more confusion and memory issues, and that presentation as those individuals age, yeah, you can definitely start to see that. I find that as they get older in that realm, you tend to see more of the dementia looking process, the confusion, low energy, just Yeah, again, main thing being confusion, forgetfulness. Like their thoughts are already disorganized, and then on top of that, they're now struggling with memory and other things that are related to it.
Um, with dealing with things like autism, which again you're seeing more and more of in society, is there any kind of a progression from or bleed over from what we would characterize as autism with schizophrenia?
Um, so there's been some in more recent years. There's been some neurological, like actual brain structure comparisons, right? Like the function of default mode network, you know gray matter, white matter, like frontal lobe activation, the way our brains talk, like the different parts of the brain talks to other parts of the brain. There's been some overlap, between autism and what we see in somebody with autism's brain and what we see in someone with schizophrenia's brain. Um, I would be very wary to compare them at all. I think there's just some structural abnormalities in both, and some of them look a little bit similar, but some of them are completely opposite of one another. Um, it does seem like that some similar areas are affected though. They might be affected differently. Um, one being enlarged versus the other being shrunken, things like that. But again, I think that the social end of things, you can maybe counter some similar presentations, but the reasons that there's the social disruption happening, I would say, are very, very different. Um, for one, yeah, yeah.
How how common or how often or how likely is misdiagnosis of schizophrenia?
That's a good question. I think that it's probably pretty reasonable that there's misdiagnosis, right? Because when you look at there's pretty subtle differences in some ways between the different disorders, right? So if somebody, for example, is hospitalized, right, and they're diagnosed with schizophrenia, and then they come in and they see me, and we're working together for a couple of months, and I realize like, oh, you actually you have like depressive and manic symptoms that are pretty cyclical on top of these psychotic symptoms, you probably have schizoaffective disorder, not just schizophrenia. And so, because schizophrenia does not have a mood element to it, whereas schizoaffective disorder does. And so, like, I would say misdiagnosis like that can tend to happen, right? Where someone will diagnose someone, oh, yeah, you have hallucinations, it's schizophrenia. It's like, maybe, but like, are they predominantly depressed? Like, where and when does this symptom manifest? Did something happen? Right? Was this after a traumatic event? Even things like drug induced, right? You can, like methamphetamine, for example, you can use methamphetamine one time and have permanent psychosis as a result, the rest of your life from one use. And so it's just, again, more rare, but it is documented that has happened. And so, um, yes, I do think that, especially in more broader settings, right, where it's like we just emergently trying to get this person the resources they need. Um, we're going to say schizophrenia when it may be one of these other 10 psychotic type disorders, would be a better fit. Um, but like radical misdiagnosis, I don't think that that's that common, right? Because you have that, again, hallucination, delusion, very strong category, of diagnostics there.
Could someone fake schizophrenia and convince you, say they did something, a murder, or they did some crime, and they want to get off, the crazy call, whatever that, and they're gonna try and convince you they had schizophrenia? I mean, what are their chances if they tried to, put on fake schizophrenia?
Exceptionally difficult. Like you would. I mean, people have tried that, right? Like that is exceptionally difficult to pull off, because not only like having schizophrenia would not be adequate for an insanity plea, right? You would not only have to prove that you have a disorder like that, you would have to prove that you were incapable of understanding right and wrong, right? And so, Like it is not just, oh, I hear things sometimes, and because of that, I can't be held responsible for these actions. It is, I am actively engaged in psychosis. Um, and I, at the time, did not understand at all what I was doing. Um, and that's just a very, very hard thing to fake. Because that would not just manifest before the crime, right? So, like, we're going to talk to, we would talk, I would talk to, I talk to family, I talk to other healthcare providers, I talk to the chances that you just suddenly have this with absolutely no history whatsoever of repetitive interventions by hospital mental health providers, case management, other places like that with very minimal family background. You'd have to fake a lot of things for a long time for that to do that. A lot of effort for over years to pull that off. It'd be very skillfully done.
Do you have, I mean, we talked a little bit about how common it is. Do you have like stats from previous decades, previous centuries, and then like today to be able to track how much schizophrenia there is in society, things like that?
Yeah. So the 0.25% number in North America comes from around 1990. And so, 30 plus years ago is what we were seeing there. Um, and then versus now, close to like 2020 to 2025, we're looking at like 1.8, 1.9 ish, something like that percent of the population. And so it's an increase, and a pretty statistically relevant increase. Though it does seem like that's probably going to be more related to the expansion of the diagnostic criteria than it would be to the actual, like, that there are more people with the disorder. Um, and so, I would want to look a little bit closer into that. But previously, like, it's schizophrenia, this category, versus now, we're looking at, again, schizoaffective disorder, schizotypal, like those other, depression with psychotic symptoms, PTSD with psychotic symptoms, like those things are all added to that percentile ranking, which would have inflated it, right? And so there's, and that wasn't part of that in 1990. And so there has been an increase, but what exactly has caused that increase, you know, hard to say.
Is there a population that's most likely or susceptible for schizophrenia, say Caucasian versus say Negro versus say Asiatic versus say South America, or these different kinds of people? Are there um, is it more or less likely among certain groups to have schizophrenia show up?
I could, I would want to double check this, but I believe it's white males have the highest prevalence of the disorder.
Interesting. So not white females and not black males or black females or so interesting. It's
I could be wrong. I like that one might be one. I would probably want to go back and check that. But
you don't, there are no patients, there are no say black male patients with schizophrenia.
oh no, I do have clients, that
Or
are.
you're saying it's most common. You're saying in that case.
Yeah, I believe so. Like, and that is me pure off of memory. That I could be wrong about that, but I do believe it's Caucasian males that have the highest rate of schizophrenia type disorders.
Interesting.
Yeah.
um, that's most of the questions that I had. Did you anything else that you can think of we didn't cover that would be interesting to those watching and or listening?
Yeah, I would say that one, I do feel fairly strongly about the media representation of people with those disorders is very, very inaccurate, right? And so if you are curious at all about that population, or how they function, there are better avenues to try to understand that disorder. Um, but the reality is that family support and having a good supportive team around those individuals can really go a very, very long way in helping them maintain good functional life status. And that's not the same for everybody. There will be difficulties chronically in that person's life, and by no means does that cause it to disappear. But I have seen some really, really amazing outcomes and interactions with these individuals. They're some of my favorite people that I know have this disorder, that I've worked with for years and years, and they're absolutely wonderful individuals. but having family support around them, good care teams around them, not everybody, it's not 100%, but it goes a really long way. And so if you have a family member or anything like that with that, being there, being supportive without being enabling is definitely something to be thoughtful about. And having that community around them and that care team around them makes a big difference.
So, I'll kind of finish with this, but if someone has someone in their family or knows someone, and they are seeing behaviors that are troubling and not sure what it means or what have you, um, what do you look for? What are the most things that say, well, this person might be schizophrenic? What do you look for that someone might, if they know someone like this, would give them an indication this might be the problem?
So if they're younger, like a teenager, right? So I'm very wary of young diagnosis. But if they're late teen, 16, 17, like just no interest in showering, socially isolating, confused speech, um, you know, in a way that is presenting way more disordered than just a confused teenager, right? Um, the I find that prodromal syndrome tends to be pretty obvious, right? Like the young person is acting very, very strangely for pretty decent period of time. And so what I would say is if you have a family member that you're noticing like really struggles profoundly with like isolation, not showering, not eating, can't organize, very confused, weird, fantastical thinking, right? Like, that even sounds like maybe on the cusp of, reasonable. Encouraging that person to go like, hey, like if you're really struggling with these things, seeing a counselor, talking to somebody, talk to a psychiatrist, talk to your primary care doctor, right? Like involve your care team, right? That's the biggest thing is involve your care team, and the earlier that you can involve your care team, the better. Obviously there are a lot of reasons that people can isolate and not care about showering and be kind of confused and disoriented. That doesn't manifest in schizophrenia, right? At all. And I'm not saying that it does, but if you notice those types of things, like be a support. Encourage that person to go get some help if they're not taking care of themselves and not taking care of their environment and they seem to be struggling to just manage day-to-day life stuff. Like always good to have a supportive care team around that person.
Awesome. Excellent. Any final thoughts?
No, I think this has been great. I really appreciate the conversation, particularly with, again, a lot of the media representation of people with these disorders, and you know, and it's nice to be able to have an honest conversation about my interactions with them because again, I have a heart for that population. I've worked with them for a very long time, and there's some of genuinely my favorite people. And so, yeah, I appreciate the opportunity to chat about them and the disorder.
Awesome. Thanks so much.
Thanks.
All right.